Welcome to the CodeCast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast Podcast today. My name is Terry Fletcher. So today I'm actually going to talk about a topic that I have not talked about before. And it's hard to believe. We've been around since November 2017, and so we are in our 7th year of the CodeCast Podcast, and I have not talked about hernia repairs. And I know we just had a recent change where they took off some of the global days on some of the repairs, and I want to talk about that. But I just really want to give you some insights that I had found that were important, and I think that the American College of Surgeons had a really good webinar on this, and they did some FAQs, so frequently asked questions, and I just want to go over some of those because you may have had some questions yourself on that, and this may hopefully clear that up. But first, the CodeCast Podcast is also brought to you today by Gold Bond Ultimate, Skin Therapy Lotion for Healing, 7 intensive moisturizers, 3 vitamins, Gold Bond Ultimate. Okay. Let's see, and I do appreciate my sponsors. We have quite a few of them right now, and we're very happy to have them. So here's some questions. So is the hernia defect or the sac measured to determine the size for selecting the correct code? So the hernia defect, yes, is the one measured, but not the sac. And then is the hernia defect measured using width or length? So, and this is really just interesting because some of this stuff, I knew the gist of it, but I didn't know some of the details. So I think this is interesting. The answer again from ACS says the measurement will be the maximal craniocaudal, so that means vertical, or transverse, which means horizontal, distance between the outer margins of the single defect or all defects repaired. And they do have a really nice diagram book too that you might want to take a look at. And then they talk about the hernia size measured before or after the opening of the hernia defect. Well, that's important. So the measurement should be made before opening the defect because the fascia will typically retract, resulting in falsely higher measurement. And so that's important to do that. We do the same thing in derm when it comes to measuring, when we're extracting or removing lesions and malignancies and margins and things like that. And then how were the size cutoffs and the code descriptors determined? So an expert panel of surgeons from the ACS, the SAGES, and the ASCRS, familiar with hernia repair, reviewed the literature that supported the code change application, and it included some comparison outcome data for different sized hernia repairs, and that helped them to make an informed decision to use 3 categories of size in their code descriptors. So now let's talk about the 90-day globals. So it says, do all inguinal, femoral, and lumbar hernia repair codes that are not changing still have a 90-day global period, or will all hernia repair codes be changed to a 0 global period? So what's happened? So only the anterior abdominal hernias, those are epigastrics, incisional, ventral, umbilical, and splenian, and peristomal hernia repairs have a 0-day global. All other hernia repair codes, including inguinal, femoral, lumbar, and let me pronounce this right, umphal-ocel, will continue to have the 90-day global period. And I think some people thought it was all or nothing, and it's not. So make sure you are checking with your CMS lookup to find out if the surgery that you're billing for has that 90-day global, because again, it's not all of them, it's only some of them. Now, if a general surgeon repairs a large incisional anterior abdominal hernia that has 0-day global, and then a plastic surgeon comes in to perform a complex component separation abdominal reconstruction, which has a 90-day global, what is the global period? Is it 0 for the hernia, or is it 90 days for the plastic surgery? So if each surgeon only reports their own code, then the global period applies to each surgeon based on what they did. But if they do this as a co-surgery, so if both surgeons report both codes, again, as either co-surgeons or even assistant surgeons, then guess what? The 90-day global takes over. It's the same thing for any of you that do GI. And a lot of people don't know this. Let's say you did a screening colonoscopy, but at the same time you did an upper GI endoscopy on the same date. Well, it's hard sometimes for the screening benefit for the patient of no deductible or copay to take effect because it kind of supersedes the upper GI endoscopy that you did that now has out-of-pocket expense for the patient because now it can change it to diagnostic. I know that's not fair, but just know that it will defer to that 90-day global if done at the same time. So patients need to be informed of that because that is a rule and it's also in CCI. And then how do global periods apply, again, for combined procedures? Let's try this again. Let's say they're different. So what if one surgeon performs maybe an ovarian tumor removal and another surgeon repairs a large ventral hernia in combination? Does the 90-day global period apply to both of those procedures, even though this is one of those hernia repairs that have a 0-day? Again, if they present their own code, then the general surgeon would have 0 and the gynecologist would have 90. But if both surgeons report both codes, then the 90-day would apply for both surgeons. So you really have to be mindful of that. Something else happened again, it's going to be the exact same thing. So if two surgeons perform separate procedures, so surgeon A performs a 90-day global hysterectomy and surgeon B performs a 0-day global hernia together, is it 90 days? Yes, if they both report the codes. So when you are involved in co-surgery and you're reporting codes that have 0 and 90 days in there, you take on the 90-day global period. And I've done a couple of audits on this already this year, one for a major payer and one for a Medicaid payer, and they threw out all the post-op care saying that you can't bill for that. So be aware that those are some rules that I think some people don't realize. Well, umbilical hernia repairs incident to a non-hernia laparoscopic procedure, so maybe a lap chole, will that still be disallowed? Yes. So a hernia repaired through the incision made to perform another procedure is not reportable. They consider it to be inherent to repair the incision of the other procedure. So it's really considered to be bundled into that service. Now, if a surgeon repairs both ventral and inguinal hernias, can the two repairs be reported together? So yes, they can be separately reported when in the same operative session because the inguinal hernia has a 90-day global, and that will be the global period for the entire operation. Now, any E&Ms or other procedures cannot be separately reported during the global, with the exception of procedures that require for a complication maybe return to the OR. But you're stuck again with that 90-day period. So the global periods are not basically, oh, we took them off, so you get to now bill E&M no matter what. That's not the case. Question comes up, how should repair of an incarcerated peristomal hernia of 5 centimeters and a primary reducible hernia, ventral hernia of 8 centimeters that are reported by 6 centimeters of fascia be reported? So peristomal hernias their codes are distinctly different than the anterior abdominal hernia repair codes. So both the peristomal and ventral hernia repairs can be separately reported, and the amount of fascia between the hernias, that really doesn't matter to coding. So the coding guidance related to distance between distant hernias only applies if all hernias are anterior abdominal hernias, so epigastric, incisional, ventral, umbilical, or spigelian. Is robotic or laparoscopic TAR or component separation reported with CPT code 15734? So when you're dealing with the 15734, this is an open procedure. So for more complicated laparoscopic hernia repair codes that may include separation components, then you may have to use the unlisted code, the 49659. The new hernia repair codes are for any approach. So it could be open, laparoscopic, or robotic. And somebody says, well, why can't, the mycutaneous flap CPT code 15734 be billed? Well, the new anterior abdominal hernia code descriptors include terminology about any reproach. So only hernia codes were reviewed and changed at CPT based on literature and level of evidence. So the repair codes will continue to be reported based on current descriptors and global period assignments, but modifications or revisions of skin or the integumentary codes for flaps or other codes, they can only be reported for complex abdominal closures that are not part of the hernia code. So they were pretty specific in that review. When anterior abdominal hernia repair is performed and the patient is discharged the next day, is this in or outpatient? And can you also charge for a discharge? So you know that they collapsed the codes for E&M in the hospital. So basically, inpatient observation care is now single code. So if the patient's admitted over to overnight observation for an anterior abdominal hernia repair and is examined, discharged the following day, 99238 can be reported because, again, you don't have global days. If you had global days, you wouldn't be able to charge for that. So if it was, and only one physician can bill for that discharge day, it would be atypical for a surgeon to transfer postoperative care to a hospitalist, and so they would not report a discharge management, and unless that was specific because they had to transfer that if there was some kind of a complication. So if a patient has an incisional hernia repair on Monday, let's say at 4:00 p.m., and is admitted to observation, and then the next morning the surgeon examines the patient at 8:00 and clears the patient for discharge, can the surgeon report an E&M service? So if the documentation supports a discharge day management on the day after the surgery, this is one of those codes, remember, that doesn't have a global, then you can go ahead and code for it. But you also have to have medical necessity for the code. So what is it that you're managing? Is that the patient do well and you're just telling them, be on your way? Or do they have to have, home health care? Do they have to have physical therapy? Do they have to be seen sooner because you're concerned about maybe the age or the recovery for that patient? That's what discharge day management is for. And remember, everyone always says, can a non-admitting physician bill for the discharge code? Only one physician can bill a discharge code on the day or days after the procedure, either the physician who admitted or cared for the patient or the physician who assumed care of the patient. So if the hospitalist admits the patient and a surgeon takes the patient to the OR to repair a strangulated hernia, let's say, and that patient stays under the surgeon's care for 2 days before the discharge, the surgeon will report that discharge code as long as there, again, is no global day on that procedure. Now, if both ventral hernia repair code and a peristomal hernia repair code are reported, is this a 51 or 59 modifier? Well, I looked it up, and the anterior abdominal hernia repair code and a peristomal hernia repair, they have an NCCI modifier indicator 1, which means that to bypass that edit when it's medically necessary, you would need a 59 modifier in the lowered valued procedure. Now, what E&M modifier is used for the decision for surgery for the new 0-day global hernia repair codes? This is a great question because traditionally, if we saw a patient on the day of surgery or for an emergent in nature surgery, we would have to use the 57 modifier. Then that would lead to the 90-day global hernia repair. But if you're dealing with a 0-day, it would be treated just like any other 0 or 10-day procedure where you would use the 25 modifier when appropriate. So remember that you only would use the 57 modifier on the day of or day before procedure with a 90-day global. So when performing bilateral component separation after a ventral hernia repair, do you need to use RTLT to the 15734 code? According to Medicare guidelines, the bilateral procedure concept does not apply to the 15734, which makes sense. I mean, you're in the abdominal area. There's really no bilateral abdominal area. Now, some private payers have different requirements, but Medicare says do not report the 50, and they do want RTLT. You just have to know their payer policies for that for specific reasons. Now, what about the new suture staple removal codes? Okay, so if you are dealing with a 0-day global procedure, can you report these postoperatively either with E&M services, or can these codes be used at an office visit after other operations, maybe a colectomy? And the codes I'm talking about is 15853 and 15854. They're add-on codes that are reported with E&M services for removal of suture staples. You cannot report an E&M service during a global period, so you cannot report these codes. So if you have global days, then no, you can't report these codes. But if you don't have global days, can you bill these codes? I don't see why not, because I don't see an edit. But you would have to have an E&M visit when they come back in. And remember, now that we don't have global days, a lot of people are like, so what do I code? Well, in my opinion, you're really not above a level 3. So it's really a level 2 or 3 established patient visit. because you're just checking their wound, you're checking their incision site, asking them how they're doing, are they following the discharge orders, and that's kind of it. So it's really hard to get past a level 2 or 3 for the visit when they come back in. And so the new suture staple removal codes of 15853 or 15854, that would be an add-on code for that. Now, the dressing change codes at a post-operative visit for 0-day global hernia repair codes, there's no specific CPT codes for changing a post-op wound dressing. So that's included in the E&M service. Do not code for anything extra for that. This is going to be just for removing sutures or staples in a non-global period. Do you have to add the 25 modifier? No, because these are add-on codes to an E&M service. And then can a peristomal hernia repair code be separately reported in addition to a reversal of maybe an osteotomy procedure? So for example, if there's a peristomal hernia after a Hartmann procedure, that's reduced and repaired during osteotomy reversal. So the repair of a peristomal hernia is actually inherent to repair closure of the wound for the reversal of the osteotomy. So you cannot code a hernia repair code there. If there was a significant amount of time or effort involved from a complication, then you might be able to look at the 22 modifier to the osteotomy reversal procedure. Ostomy. Sorry, I'm just like tongue-tied today. Ostomy reversal procedure and supporting documentation would have to be submitted. But try to be careful when you submit that 22 modifier. Not all payers like it, especially if you're trying to get around something that's inclusive. And lastly, I'm going to talk about the diagnosis code reported with the post-op E&M visits for 0 global hernia repairs when the patient comes in for just, again, a simple wound assessment and staple removal, which you're charging for both of those. So I would report the primary hernia diagnosis code that was used for the surgery in addition to a secondary diagnosis of Z48.81, because that's an encounter for surgical aftercare following surgery on a specified body system. And that's a secondary code. And I think that would be appropriate for the encounter. Okay, I hope this really helped as far as your hernia understanding. I know I kind of went in depth there, but I just thought it was important to probably bring up this specialty for a change. I haven't done it. I can't believe in 7 years haven't talked about hernias. It's hard to believe that we came up with a new topic, but we always like that. A couple of, just a personal thing, I always give you a tidbit at the end. So it's getting warmer. I'm getting in my pool. And some of you that know me, I was struggling a little bit, not just with weight, and had a new diagnosis last year of diabetes. And I'm down over 70 pounds from using my pool, really eating correctly, staying away from sugar. I am going through withdrawals from no chocolate chip cookies, though, I have to tell you. But I'm pretty happy with that. Now, everybody keeps saying, but now, Terry, is your knees better and everything? No, everything's still, come on. Once you get over 50, especially over 55, where I'm hovering right now, things still bother you, but it's really nice just to see the difference. And for anyone who's reached out and asked me, how I'm doing with that and has seen me recently and said, oh my gosh, you look great. Thank you very much. It means a lot to me, and I just really appreciate you noticing and, caring about me personally. So before I get emotional and start tearing up, I just want to tell everyone, thank you for caring about me personally again, and make it a great day, and thank you for listening to the CodeCast Podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.